Good afternoon, everybody. Good morning, good evening, wherever in the world you are. I want to welcome you to this webinar to the topic Revision of RY Gastric Bypass. What are my options? We have more than 200 registered attendees, and I think we have today a very interesting speaker with a huge experience, Professor RY Gastric Bypass from the Netherlands. He's professor at Wageningen University since last year and holds a special chair on nutrition and obesity treatment. Furthermore, his center does more than 1,400 operations per year. He's a very heavy scientific publisher. I give you an example. In 2020, you find more than 15 published papers from him in Medline, and overall more than 100 papers. We also have some poll questions I want to go with you through before Eric starts his presentation, and we prepared 2 poll questions for you. Can we have the first poll question, please? So number 1, which surgical option do you choose for weight regain after gastric bypass? Distalization, pouch revision with a ring, BPDDS or SADIS, I would say. We can make both options or other options. So please vote now. Okay. Then we go to, let's have a look at it, okay. So distalization, revision with ring are all pretty the same. Duodenal switch, SADIS is not really the most common option, and also other procedures I would include, let's say endoscopic procedures are also not that very common. I'm looking forward whether Eric's talk will change on that point of view anything. Then our second question is, we have another one. Now, which surgical option do you choose for insufficient weight loss, which is different from weight regain? Please keep that in mind. Which surgical option for insufficient weight loss after RY gastric bypass? Again, distalization, revision with ring, DS, other. Please vote now. Can we see the result? Yeah. Okay, so for insufficient weight loss, the picture is a little bit different. We have more distalization, less pouch revision. We do see the ring, and other procedures are much more common, whereas BPDDS, SADIS still stays the same. So very interesting, and let's see what changes after the talk of Professor Hazebrook. And I would say the stage is yours, Eric. Please.
Thank you, Gerhard, for this nice introduction. Let me adjust my screen a little bit. Somehow I cannot move. Yes, these are my disclosures to start off with. But first of all, I would like to show you this picture, which I found in preparation of this talk, and was almost exactly a year ago when you visited me during my inaugural lecture. And well, it was a very pleasant day, and who would have thought that a few months after that the world would be a totally different place. And well, I'm very thankful that we at least have these options, and thanks also for Bariatric Solutions for facilitating these types of webinars, so we can at least be in touch, and let's hope the world will be in a better place soon. So the gastric bypass, that's what we're discussing today. It has been around for over 50 years now. The first publications by Edward Mason. It has underwent some changes, of course, but still today, 2020, it's, at least in the Netherlands, it's one of the most performed bariatric procedures out there. We all know that the sleeve gastrectomy has surpassed the gastric bypass in numbers worldwide. But at least in the Netherlands, the gastric bypass is still considered the gold standard. Very effective operation in terms of weight loss and resolution of comorbidities, as we all know. But what we also have to acknowledge is that a serious amount of patients, and it probably will be around 25 to maybe 30%, who has an insufficient result in terms of weight regain or insufficient weight loss. And when that happens, of course, we need to prepare patients that it could happen. So you need to counsel them before the operation, of course, but after it happens, counseling will be the first step. And we'll talk a bit about that in more detail in a minute. But first, we have to consider the etiology of weight regain, because like many other things, it's multifactorial. And one of the first things you have to consider is that we need a good assessment of the nutritional habits of a patient. And of course, if psychological influence is contributing to that weight regain. Genetics, of course, is a factor which is very difficult to influence, but it is also a main factor why the operation is successful in one patient and less successful in another. Behavioral treatment and consultation by a dietitian is one of the first steps you need to consider when weight regain has to be addressed. But of course, also the anatomical changes need to be acknowledged. And a barium esophagram is one of the first steps. And you can rule out a fistula. You can look at the gastric pouch volume. Sometimes a gastroscopy is very helpful. And of course, a dilation of the GJ anastomosis. So when you look at the literature that's out there for a failed bypass in terms of endoscopy, there are some nice studies out there. And this is one by Barham Aboudeya, who we were very pleased to have visit us at our annual meeting recently, who has this study which shows that the stoma diameter in gastric bypass is a contributing factor, and that the wider the diameter, there's a relation with the percentage of weight regain. So that means that maybe with endoscopy you could readjust the anastomosis. Of course, you can do it surgically, but endoscopically would be very less invasive. And I would briefly mention some of the options that have been described in literature. This is a study by that same author, who is very much experienced in endoscopic revisions. And this is a study where they use sclerotherapy for the outlet reduction by injecting a substance which is mentioned here, which I'm not familiar with, but what you can see in this graph is that at least after a few sessions, there is a significant stabilization of the weight regain. There's a little bit more literature on transoral outlet reduction by means of stitching. And this is something our gastroenterologists in my hospital also use. And the goal here is to reduce the stoma size by placing sutures. And here you can do that with the Apollo overstitch device. This is a fairly recent study in which they collected the data from 3 institutions, over 130 cases, and you can see that even after 2 years, there's a reasonable result on terms of countering weight regain. Here in the left column, you can see it. There's some variations in how you should apply those sutures. This is a technique which is called transoral outlet reduction with a purse string suture. Again, successful weight change after a year. And there is even a study which says if you use these techniques, you should use a purse string instead of an interrupted technique, because it adds a little bit more weight loss. But all are very limited studies, limited in follow-up duration, and they're relatively small studies. So the surgical approach, has been a lot more literature on that, and this is one of the key papers, I think, a couple of years ago by Tran and colleagues. And what they collected all the studies. They collected 24 studies, which you can see here in detail, over 800 patients. And what they say, well, if you look at the literature, there's no standardized approach for a revisional procedure. What they do mention is that the distalization, so the distalization of the gastric bypass has the highest complication rate, and also there was the only procedure with a mortality rate described, and the revision of the anastomosis or a pouch revision had the lowest complication rate. So from those surgical procedures, these three here had the most success in terms of sustained weight loss, and in their opinion had also acceptable complication rates. So I will discuss these procedures a little bit more. This is also a very interesting study by the group of De Maria, who actually looked at terms of persistent satiety in case of initial weight after a period of weight regain or weight recidivism, they call it here, in terms of satiety. In case patient had satiety, they were administered to behavioral treatment. In case there was no satiety, then they would rule out abnormal anatomy, revise the pouch, or even performed the more drastic procedures such as the distalization of the gastric bypass or even duodenal switch. So they mentioned about 96 patients in which they performed distalization of the bypass. And what you can see is that they call it the total elementary length, the limb length, which is very important to consider in distalization of the bypass. And in terms of problems after that procedure, you can see that at least 400 centimeters of total elementary length is needed to prevent diarrhea or malnutrition. Altogether, they found a significant improvement in weight loss, effective reduction in comorbidities, but of course with the obvious counter effects such as low albumin and vitamin deficiencies. So as Gerrit already mentioned, we have a very large clinic and perform a large number of bariatric procedures. But of course, we also see a lot of patients who have insufficient results. So that was a reason for us to look a few years ago to look at our data in case of revisional cases and to see what is now the best approach for a patient which in terms of insufficient weight loss or weight regain. And the most performed procedures, at least in our hands, was banding the pouch with a minimizer ring or performing a distalization, so which in our procedure would mean shortening of the common channel. But of course, we first looked into the literature. So this is a bit older study by our Belgian colleagues who about 10 years ago published a small series in 6 patients with weight regain and placed a ring around the pouch. And they said, well, this is a very effective rescue operation. So placing a non-adjustable silicone ring could be a very effective operation for weight regain in case of unsuccessful gastric bypass. Oddly, the same group a few years later also mentioned that they did have some complications. At least 2 erosions were mentioned Again, a very small series, but with a message that is very clear, that adding a restrictive aspect can be performed in various ways. So you can refashion the pouch, you can place a ring, or you can do other sorts of procedures, which can be effective at least in the short term. But they said be careful with a constricting band. Again, this paper I briefly mentioned before said, well, if we look in the USA, there are not that many procedures with a non-adjustable band because that is not commonly performed. So that is basically more performed in the European countries, I think. But the conclusion is that we do need more long-term studies because we need more data on revisional cases with a non-adjustable band. So that's the reason why we collected our data and joined forces with some other groups. So this is basically the schedule we had for this approach. Showing all patients with a failed bypass were administered to nutritional and behavioral coaching, and if that didn't work, they were selected for revisional surgery. But what I will mention here, that I think there is a difference, and that is something that we recognize over the last few years. There's a difference in patients who have weight regain, so who were first successful and then regain weight, or patients who were not successful in the first place. So this is just some unpublished data and to see what how we performed this. Just a second, I will show it here. You can see that we performed in those failed groups. In those failed patients, we either did a band or we did a distalization, and then we looked, well, which patient had a result after insufficient weight loss and which patient had a result after this band after weight regain. And you can see that there were, when you compare those two groups, so in the left graph we have the group with insufficient weight loss, in the right graph you have the weight regainers. You can see that for the insufficient weight loss, that the distalization was much more effective after a year, whereas the banding didn't do very much. And for the weight regainers, there was a successful effect for both procedures. Of course, those are very different procedures with different consequences, you might say. I will discuss that later in more detail, but the obvious side effects are malnutrition for the distalization, and in terms of the banding, there are some problems with vomiting and food intolerance. So then we thought, well, this procedure is widely performed, but probably not so widely published, and that's why we joined forces with 3 other hospitals in Germany, Berlin and Cologne, and 1 in Switzerland in Basel, and we added our we collected our data. So we came up with 79 patients who had minimizer ring placement after a gastric bypass, 6-year period. First year follow-up was 86% and a reasonable follow-up after 2 years. And again, we divided those groups in poor responders and good responders after gastric bypass. And what you can see, as depicted here, that the gray line is the group in total. So you can see the gastric, this is the time of revision, that after placement of the band, there was significant weight loss, and the effect was obviously higher in the good responder group. But what we noticed, that further regain of weight was prevented in a majority of patients. At least 75% had a benefit in prevention of weight regain, and at least a third of the patient had a higher weight loss than they ever reached after their initial procedure. We published this earlier this year. However, there were some remarks to be made, because we had a significant number of ring removals, so some ring problems. So we had to look into that because we don't recognize that at our current procedure. So there might be a slight learning curve here. So we analyzed it in more detail, and as you can see here on the right, you can see that the majority of band of ring removals, I must say, was in the early series, and there was also a correlation with the ring diameter. So that means that the tighter the ring, the more chance there was for ring removal. So the advice is not to place the ring too tight. So summing this up, the non-adjustable ring for a failed bypass, I think it's a procedure which has a low major complication rate. It doesn't require any significant modifications to the anatomy, and it can be performed with practically zero mortality. So it's basically a very safe operation. And it could be that this is a very good option for weight regain, and maybe a little less for the insufficient weight loss patients, but there is a group that responds very well. I always explain our patients when we see them, when they ask for a ring or when they ask for a second procedure, that you somehow have to manage their expectations, because the effect on weight loss is modest. Some patients will come to you and say, well, I need to lose at least 40 kilograms. Well, that probably is not going to happen, but you have to explain that it's a good procedure for preventing further weight regain. For reasons of dysphagia and band removal, the advice is not to place the band too tight. And of course, again, like very much studies out there, we need longer outcome. So the other group I mentioned, the distalization, we also had a recent publication on that, and we looked at our data over the last few years. This was published in Obesity Surgery. Again, the idea here is that there's a subset of patients who don't lose weight sufficiently after gastric bypass. Of course, they have counseling. I must stress that every patient will first go to a nutritional evaluation. We'll have at least a couple of sessions to get them back on track. But if that doesn't work, we probably need to look out for something else. There are different types of distalization, as you probably will be familiar with, either by lengthening the biliopancreatic limb or the alimentary limb. We decided to perform a procedure that was combining the two. So in all cases, the common channel would be 100 centimeters, and the alimentary limb at least 250 or 300 centimeters, which means that the BP limb was the remaining length, which was in most cases around 200 centimeters. And that would look something like this. I hope you can see this. So the purple arrows are the common channel. We had 44 patients which we were able to analyze for a significant period for approximately 4 years. And of course, if you look at the primary outcome in terms of weight loss, that was very effective. Again, here I divided this graph in poor responders and good responders. And what you can see is that after the distalization, there was a significant reduction in weight. And the majority of patients was able to lose at least achieve a total weight loss of more than 25%. However, that obviously comes at a price. When we look in more detail, there was a large subset of patients who was deficient for various vitamins. Although all patients were prescribed optimized multivitamins, there was at least 2/3 that needed extra supplementation and regular follow-up by the Department of Internal Medicine. So that means if you perform these types of procedures, you need to be very careful, and you need to measure those different vitamins. And they're depicted here. The majority was selenium and zinc deficiencies. But there was also a reasonable subset of patients who had albumin deficiency. So that means that it's a very effective revisional procedure in terms of achieving weight loss and probably also achieving resolution of comorbidities, because they go hand in hand. And you can see that here, the diabetes and hypertension remission is very good, but it comes at a price of the deficiencies. You need to be very careful and be very strict in your follow-up. Of course, the diarrhea or the defecation pattern, if you will, is something that needs to be addressed, although the majority says that they can reasonably live with that in terms of 5 or 6 defecation times per day. Some patients would even have 20 per day. And of course, obviously, that will lead to a reduction in quality of life. Some patients had to be reoperated again to lengthen the common channel. And well, quality of life, there's obviously a wide variation. So this type of procedure and these results have made us decide to reconsider the way we perform distalization, and maybe we can discuss that after this presentation. So we are talking here about surgical solutions and surgical options for a failed gastric bypass. But the question is if surgery is the answer for everything. And as we all know, or probably expect, a magic pill is years away and probably will never happen, because obesity is a difficult subject and too difficult to counteract with one pill, I think. But that doesn't mean that medication is a good option for a revision after a failed gastric bypass. And this is a recent study in which they show, and you can see it here in this column depicted in red, that a period of intravenous liraglutide compared to placement of a ring and pouch reduction is probably similar in effect. So that means that using liraglutide as an adjective could be very useful, and there are currently some studies being performed. So I hope that we can learn a little bit more about that in a few years. And this is their conclusion: weight regain, and this was even 6 years after bypass, can be safely and effectively reversed, and should be considered a valid option to treat weight regain after a bypass. So contemplating on how to prepare this lecture, I came up with the name giver of the university I graduated from, and a famous saying by Erasmus is, "Prevention is better than cure." So when we talk about revisional gastric bypass and the options, that also could mean that we should do it right the first time. So maybe we should perform or improve the way we perform the bypass better. So we all know that's probably the holy grail, because there's not one option, there's not one way to perform the bypass, but it doesn't mean that we can look in more detail in how we should perform the bypass in the first place. And I will briefly sum up some of the studies we have performed in our center over the last few years, focusing on the pouch and focusing on the bowel limb length. This is the recently published study by one of our PhD candidates who published the results of a randomized trial in which the pouch was lengthened. So you have a standard gastric bypass pouch and you have a more longer, narrow pouch. And what you can see is that the longer pouch, a bit similar like what we know from the one anastomosis gastric bypass or omega loop bypass, is that you can see that it's a little more effective, and people probably have a better result. So it's a safe procedure. It in terms of hypertension, there was a better remission rate, and quality of life was good in both groups. But the key message here is that a longer pouch probably will induce less weight regain. A lot has been said about the length of the biliopancreatic limb. Two randomized studies from our center that have been published. This is the primary gastric bypass, the elegance study, in which the routine gastric bypass used to be a biliary pancreatic limb length of 75 and an elementary limb of 150, and the longer BP limb had the lengths switched, so the other way around. And in terms of excess weight loss, there was a significant increase, but after 4 years, the total weight loss was similar. So you can sum these results up that there is an effect, although it will be modest, but it doesn't lead to more complications. We use it, the limb length of 150 as our standard gastric bypass, and one of the reasons for that is that we also performed a study in conversion of a gastric band, so the revisional gastric bypass, and then you do see that the total weight loss was significantly higher even after 4 months without differences in other parameters between the groups. So that's a procedure the patients can tolerate very well. Again, the non-adjustable banded bypass was mentioned as a revisional procedure, but when you look at the literature as a primary procedure, there's a lot of evidence that it could be a very good option to use it in the first place. So this is a very well-known study by Luc Lemmens, a single-center cohort with a large sample size. They used this type of celastic ring of about 6.5 to 7 centimeters, and a very excellent follow-up rate after 5 years. Of course, a number of band removals and readjustments, but less weight gain after 5 years. And when you look at the literature in terms of systematic reviews, they all show that there are various types of rings and bands used over the years, even pericardial patches. I don't know if that's a reasonable alternative to consider, but various diameters, and they all point to the fact that the banded gastric bypass induces superior weight loss. Of course, with a risk of band removal and a risk of food intolerance in case the band is played too tight, but still it is an effective way to maintain weight loss. In the Netherlands, only one center, the center in the south of the Netherlands, Jan Willem Geven, has published widely about this, uses this as their primary procedure, and this is one of their recent studies in which you show, and for this study they combined primary procedures and revisional. So if you look at the purple line, that is the line that depicts the primary procedures, you can see that after 5 years they have a very excellent weight loss result in their banded bypass procedures. We are currently not performing it as a standard procedure, but that's the reason for that is that we first have to await the results of our randomized controlled trial, the Bandolera trial, which we are now in the process of collecting data on our 5-year follow-up. We could identify a trend after 3 years, but we have to await those results when the data are complete. So summing this all up and trying to achieve a take-home message here, I think you can add this as the following. When you consider performing a gastric bypass as a primary procedure, there are some adjustments you could consider, whereas you can make the pouch a little bit longer and narrower in terms of preventing weight gain. Probably also for the biliopancreatic limb, although in our study that was a modest effect. Appended bypass, there is definitely evidence that induces less weight regain in case of a primary gastric bypass. And in terms of a failed bypass, I think for weight regain, there are various options. I mentioned the outlet reduction and I mentioned medication, but those are very preliminary results. There's a little bit more published on appended bypass, so I think that's a reasonable alternative for the weight regainers. And patients with insufficient weight loss could definitely benefit from a distalization procedure, but of course that comes at a price, so you need to beware of those side effects I mentioned. Future studies, in my opinion, should include more prospective data collection, accurate prospective data collection over a number of years. And I think we need more detail on selection, and that also is important for patient selection in terms of a revision on gastric bypass. And one of the key factors here is that we should document eating behavior characteristics in more detail, and that is I think one of the challenges for our research in bariatric surgery, but it's definitely one of our focus points for the next few years. So having said that, I want to thank our entire team of researchers and bariatric surgeons for helping me collecting those data, and I thank you very much for your attention.
Thank you very much, Eric, for that wonderful talk with your own data and also review on the literature. I think we'll have now a nice discussion, and please all attendees don't hesitate to post your questions. One, of course, of the most burning questions is, what do you consider to be a failed gastric bypass?
Yeah, well, that of course is an excellent question. That is actually the most important question, and that is also the first question, or at least subject, I discuss with my patients when the patients are referred to us for weight regain after a few years after bypass. So what I always show them is their initial weight and their current weight, because in most cases they would never have been able to get that result, even if the result is disappointing in their opinion, without an operation. Because they usually will still have about 20 kilograms of weight loss, which they never would have been able with a diet. And that also, of course, is very important in terms of comorbidities. But so, and for that, I mean the comorbidities can be reduced, but the weight could have come back in at least a certain amount. And I think that is.
Yeah, sorry.
Well, I think that is very important to address, and we focus a lot on weight and weight loss result and weight loss outcome, and that is very obvious, and it is very reasonable, because that of course is the reason why you perform these procedures. But we should not forget all the metabolic effects that our operations induce as well. So a failed bypass, there's no one definition for a failed bypass, in my opinion.
The background of my question was because in your data, you showed an excess weight loss of less than 50% as a definition for failure. And of course, if you make that definition, my next question will be, the probability of failing increases with initial BMI. If you operate on the majority in super obese patients, then you will have, of course, a much higher failure rate, considering that any bariatric procedure usually reduces a certain BMI point in a range. You would agree on that?
Yeah, and I fully agree with you. I think the reason why we put that excess weight loss is because the studies at the time were designed when we used the excess weight loss of 50% as a reasonable cutoff point, whereas nowadays we more use the total weight loss. And as you could see in the more recent studies, we even had that total weight loss set at 25%, which probably is a bit high, because why wouldn't the total weight loss of 20% not be successful?
Yeah. So we have now several questions. One question is, I would say barium swallow is by far inferior to 3D CT reconstruction for evaluating anatomy volume. Do you perform these 3D CT volumetries?
No, I wouldn't agree in part. I think a CT scan is probably always gets more definition, gets more detail about the anatomy, but it's also more expensive. It depends on your facilities in your hospital, I think, whereas the barium swallow is a very easy tool to use, I think. It's also very effective, the barium swallow, to see if there's a gastric fistula. Of course, that of course will not happen that often, but it's very important to rule out if that's the case and people regain weight. Yeah, that's a no-brainer that you should do something about that. But the barium swallow, in case the bypass is really not well constructed or has adjusted, I could say, then a barium swallow is very effective. In case of a normal bypass, it doesn't tell you that much, I think.
Yeah.
But so then again,
that fits perfectly to that topic is, what do you call increased gastric pouch volume?
Yeah.
Well,
we always say that we make a pouch of around 30 cc's or something, 30 to 50 cc, but of course you don't know. But why it's important is to do radiological workup, I think, because you cannot get enough information by the operative charge. Usually the patients are operated in a different center. If they're operated in your own center, you probably know the technique that was used, but if they're operated in another center, that might be difficult. We also know that in case there was a gastric band in the past, that could be that there's a lot of fundus left because the dissection was difficult, or thought that it would be too dangerous to dissect the pouch too narrow. I think you can tell, but you also often see is that it's not so the pouch that widens, but it's more the jejunum, which is very wide. So often you can see a long blind limb, or then that it's not as we intended it to be in the first place. So it's not often pouch dilation, it's usually a combination of the two.
I fully agree. That's what I also often see, that the first 15-20 centimeter of the small bowel diameter enlarged dramatically. And for me, the reason is that the muscle wall of the small bowel is much thinner than of the stomach. So the dilatation occurs much faster and wider than with the stomach.
Yeah, so I agree. I think that the bowel, the size of the bowel wall is very important.
And then this becomes a kind of a neostomach. People eat not only into the stomach, but if the stoma is wider, then this first part of the small bowel becomes also part of kind of a neostomach. That would be my theory why these people have lost the feeling of satiety.
Yeah.
So we have a lot of other questions. One is, for instance, what about pericardial patch as an alternative to a band? If it can be used, can we consider any fascia as an alternative to a band?
Yeah, I have no experience with pericardial patch, but I know the publication. I also know it was mentioned in one of the previous webinars by Jan-Willem Geven and Evert-Jan Boerma. I would say in terms of the material, I think the silicone ring would be much more effective, I think. But obviously, I never performed a procedure with the pericardial patch, so I would not use it. I think the way the rings are produced nowadays are very well. You can handle them very well. They're very well tolerated. So I would definitely prefer a more well, not rigid. It's still flexible, but a more rigid type of ring. Than a type of ring.
How tight do you make the ring? Do you prefer for visual procedures a certain diameter?
Yeah, that's always a difficult question that we discussed there. If you take the minimizer ring, there are 4 ways to adjust them, varying from 6.5 to 8 centimeters. I know that people like Jan-Willem who perform it as a primary procedure use a difference in male and female. They use a 7 and in female and a 7.5 in male. I don't think that will work every time, because obviously there you could run into a case I did the other day as well, that there's a very thick gastric wall, and even the widest setting at 8 centimeters was just right to get the instrument. So that's what we do is the band has to be loose. The pouch, the bougie has to come through easily, and you have to be able to pass a 5 millimeter instrument easily, at least. But it's not as much a restriction ring as we know from the gastric bands. It's more like a loose ring around the pouch
to prevent dilatation of the anastomosis and later on of the small bowel.
Yeah.
We have another question. Which patient would benefit the most from a primary banded bypass in your experience? So to whom would you do it as a primary? Is there any...
Again, I think it's very important to look at their eating behavior. So probably the reason why the primary gastric bands are so successful is that the food intolerance is used as a beneficiary effect, because people think it's a positive. They know they get trouble when they eat too much amounts or too copious meals or too much solid foods, and that's probably the reason why you should select the patients correctly, because not a patient who doesn't really understand that could happen will complain a lot of vomiting, and will complain that the band's too tight, that he or she has complaints in her upper chest. So basically, a patient who is able to understand what adjustment of a meal after these procedures entitles.
This leads me to another question. You showed in the revisional data that the band removal rate was quite high, especially when you compare it with the data from Luc Lemons with 2% only.
Yeah.
So do you think that patients who had a normal gastric bypass without a band have a different eating behavior, and then when you add the band, as you mentioned, feel this additional restriction sometimes being too hard to stand?
Yeah. Yeah, that's a very interesting remark. I think that could definitely be a contributing factor. That the way they eat changes, obviously, to a way they were not used as much before. But again, it shows that there's not just, you have to select each time, you have to look for the diameter, and the band has to be not too tight. And in the early cases, I think if you see that, you have seen, you're doing this procedure, so you see that band and it's very loose on the pouch, and you think, how can this work? What does this contribute to for an effect? Because we're always used to those gastric bands sitting nice and tightly around that pouch. Then again, it's a different way of thinking, because the pouch will dilate and people will have a wider or bigger bolus, which they have to swallow, and then it is effective. And maybe there are other factors as well. Maybe it's the gastric emptying time that's also important. We're actually looking into that as well.
Yeah,
to see if that's a contributing factor.
We have many other questions. There is one that really think is interesting. You mentioned counseling before redoing a reoperation. What is the percentage of patients that you could avoid a reoperation by counseling, which means you were successful to lose weight with counseling? In my experience, this is a very, very low rate. But
yeah, I agree. I don't know the exact amount, but that is. I think what we always do, we have a back on track program, which usually takes about 4 sessions with a registered obesity nurse who's very skilled in detail about making readjustments to their eating pattern, looking at all psychology, about if they experience stress, how's your situation at home, looking at the bigger picture, and of course having and taking the time to talk to your patient, because we always, as surgeons, only have 10 to 15 minutes per patient, which obviously is not enough. And there is an amount of patients, a number of patients that says, well, okay, this is good for me, I don't want to. But if they really are eager to get another procedure, yeah, they probably end up with having this procedure, because again, it's not so much that they will lose weight after counseling, it's to prevent further weight regain. And I think if you look at the bigger picture, if you look at obesity as a chronic condition or disease, if you will, then we also need to address that during life and over the years you should add a little bit more, and maybe in one case it is counseling, and then the next step will be medication, and maybe after that a procedure. But I think we have to change our way we think, but also explain that better to the world outside, to start off with our patients, because
it's a very important point. Eric, you also showed your experience with distalization. I have the same experience. I've doing this for so many years, and I was very enthusiastic in the beginning. Later on, I still had nice results in terms of weight loss, but in the long-term run, you pay a horrible price in my mind. So to be honest, I avoid distalization as much as I can. What is now your current approach to distalization?
Yeah, that's appealing to my conscience very, very much, because after looking into our results in detail, as I showed you in our publication, then we thought, well, this is definitely not worth the price, because obviously you will have a good result, but patients have to pay a big price, I think, because a lot of them are they're getting into trouble at the internal medicine department and need a lot of supplementation. So I think definitely the 100 centimeter common channel is too much, and probably that should be at least 200 or maybe
too much
250.
Malabsorption, you mean?
Yeah, I think so. And of course, that again, it's you're leveraging out, and maybe in terms of successful weight loss, but somewhere there has to be a balance. Actually, there will be there are plans of starting a study now in the Netherlands, which sets with doing a randomized study for distalization, fixing the common channel length at 200 centimeters, and then varying the elementary limb or the BP limb. And maybe that will give us better results. But again, the problem with those retrospective studies is that the subset of patients is very heterogeneous. So what will work for one patient who is able to eat a lot of solid foods and even healthy food or meat or vegetables, whereas another patient will be much more restricted and will get more in get into trouble earlier because he can't get his protein and his albumin levels up. So I think before we anticipate subjecting patients to these type of procedures, we have to look very careful into their eating behavior.
Yeah, great. We are running a little bit out of time. We have so many questions, which shows that this is an important topic that affects all bariatric surgeons and looks like a lot of patients. One other question is, what about vicryl mesh wrapping of the pouch and stoma? Which means any absorbable mesh.
Yeah, vicryl, in my opinion, would not work because it will be absorbed, and it might give a temporary effect. Whereas the silicone, of course, will be, will stay there, hopefully. So I would not recommend putting an absorbable ring or mesh.
Another question is your experience with erosion. Do you have experience with erosion, and how did you handle the eroded bands? Could you remove it simply by endoscopy, or did you have to go back? Was it a tough thing?
Well, it's pretty similar to our experience with the gastric band. So you have to team up with your gastroenterologist, and sometimes you have to schedule a patient for a combined procedure. So start off endoscopically, and then do a laparoscopy at the same time. In the Netherlands, at least, we have the gastroenterologists that perform the endoscopies. I know there are some differences in other countries. Unfortunately, that is the case in our situation. So you have to be very good friends with your endoscopist, and usually that at least we have not had many problems with that. I think the mesh, like we know from the hiatal hernias, that is often more of a problem than those silicone rings. Those are very easily removed, and they're also at a very more forgiving anatomical situation. I mean, the stomach is much more forgiving than the esophagus, of course.
That's a great point, I think. Yeah. Okay, one last question. Does the ring have any effect on dumping?
Yeah, well, that is a good one. I haven't on purpose, I haven't showed you that because I simply don't have the data, I must be honest. But we're looking into our results for that, because you could make a case that the gastric emptying times will be delayed, and that also placement of a ring might influence the way people experience dumping syndromes. I know there are some surgeons in Europe that perform it for that reason. So what our first step is to.
Fritz Horber, you showed the data of these two guys.
Yeah.
Fritz Horber, they were the first one who published, I think, 11 patients where they placed the ring for late dumping.
Yeah. That might be a good alternative as well. Yeah.
Great. Eric, thank you so much for that fantastic talk and very vivid discussion. I want to thank all the participants for all the questions. I hope we covered quite a lot of them, and we will answer the rest then in email. And I thank all of you for attending, and especially Eric for this wonderful presentation, and Bariatric Solution for enabling this webinar. Thank you all and have a safe day. Bye-bye.
Thank you very much.